Hey, so I'm gonna go over the meds that we gotta know for this test tomorrow. If you don't take this class, I'll just go over them by topic. If you have any questions, let me know. I have a list made right here that I put together. So I'm just gonna go through it pretty quickly. Antiplatelets, which are aspirin and Plavix, usually are used to prevent cardiovascular problems in patients with peripheral arterial disease. Okay, and the correct dosage is 75 to 325 milligrams of aspirin daily, and that's for prevention of CVD with PAD. The side effects are bleeding and could be tinnitus in aspirin. Um, yeah. And then the nursing considerations is that when Plavix is given with omeprazole, which we should remember from last test, it's a GI med. It reduces the med by about half, so it increases the risk for stroke and cardiovascular events. And then silostazol is used for intermittent claudication, and this increases the camp in blood vessels, and it produces platelet inhibition, which produces vasodilation, and vasodilation kind of like lets the blood flow through more quickly. And this is important to know. Do not use this in heart failure. No matter what kind of severity it is, do not use silostazol in heart failure. All right, I'm going to say that again. Do not use silostazol in heart failure. Okay, the next one is pentoxaphylline. All right, this is for intermittent claudication again. It improves the deformability of the red blood cells and white blood cells, and it also decreases fibrinogen. Platelets become less sticky, and it decreases the blood velocity, which does help with intermittent claudication, getting the blood to move more freely, not get stuck together. And you should eat this medication with food to decrease the upset of your stomach. Prostanoids are another class of medication. A good example is iloprost, and this is for leg ischemia when they're not candidates for surgery, or PTA, which is percutaneous hold up for me. PTA. I will figure it out for you, I promise. PTA. Okay, a PTA is, I just forget what it stands for. But it's not. It is something that opens the blood vessels to let oxygen through. But I'm just gonna get back to you in a second on what it stands for. My apologies. PTA. Okay. Percutaneous transluminal angioplasty. Okay. So that's recommended for patients who aren't eligible for surgery, and if they're not eligible for either, then we want to give them prostanoids IV, and they can also be used for Buerger's disease, which is an inflammatory condition of the veins and arteries, so its purpose is to decrease the rest pain, and it improves ischemic ulcer healing. And it hopefully will decrease the need for amputation. One thing important to know is that it's used IV, and you have to make sure they're still taking their other medicines as well. Basically, We just want to, keep it from being dislocated, control infection, stuff like that. Okay? So next is for diabetes. I did a whole video on like most of the oral meds, but there's a few more that we can go over now. So if you don't understand the other oral meds, please go back to my other video. I'm not gonna review them again. But all right, so sodium glucose cotransporter inhibitors. Well, actually, let's start with the dipeptidyl. So the dipeptidyl peptidase 4 inhibitors, also known as the gliptins, are incretin hormones, and they're used for diabetes type 2. And they cause a release in insulin secretion and a decrease in glucagon secretion. And they are glucose dependent, so they're lowering, it's like a lower risk of hypoglycemia because your dosage depends on how many carbs you have, which is really interesting. The way your body handles it depends on how many carbs you have. And sodium glucose cotransporter inhibitors are the FOSNs, right? And these are for type 2 diabetes. They block the reabsorption of glucose in the kidney, and that makes increased glucose excretion. So I know I was really confused when I saw that. I was like, why would we want extra glucose? But it's saying that like excess glucose is removed in the urine. So that's what this does. It's decreasing blood glucose levels by removing the glucose from the urine. And dopamine receptor agonists, a good example is bromocridipine, type 2, and they're thought to have low levels of dopamine activity in diabetes type 2. So this medication will increase the dopamine activity, which will hopefully hopefully control the blood glucose levels. And it can be used alone, or it can be like an add-on with a different medication when diabetes is not controlled by just one. And then we have the glucagon-like peptide 1 receptor agonist. That's a mouthful, right? Those are also used for type 2. And yeah, so basically they stimulate the incretin hormone, which increases insulin. It helps with satiety, so like you feel full faster, and it inhibits glucagon secretion, and it slows gastric emptying. So there are a few different meds, but Byetta, which is the first one I have here, the exenatide, that can cause acute pancreatitis and kidney problems. So you need to make sure if someone has already kidney problems that you don't give them Byetta. And don't use liraglutide or dulaglutide with a history of medullary thyroid cancer. And also these are two that acute pancreatitis is associated with. So we're going to administer all these meds subcutaneously. In the purple, right, the purple ones are given once weekly, so once every 7 days, okay? The orange one is given once daily, and then the red one, Byetta, is given twice daily, all right? So that's good to remember in case there's a question on it, in case you have a patient with one of these medicines, more importantly, and you need to know when to give it to them. You know, you're not going to be giving the dulaglutide every day, right? That's just not, that's given once weekly. Okay, so the amylin analogues, the only one they have right now is pramlintide. Again, I'm really sorry, I can't pronounce any of these names for the life of me. But it's used for type 2 diabetes, or it can be used for type 1, but it's just an extra to mealtime insulin when there's insufficient glucose levels with insulin. So this can cause severe hypoglycemia, especially during the first 3 hours of the injection. So you need to tell patients to at least have 250 calories right after. and also they need to carry some kind of rapid-acting glucose with them in case they become hypoglycemic. And these aren't injected into the arm. They're only injected into the thigh and abdomen because the arm, there's less reliability. So, and then antiplatelets. So this is for strokes now. We're on strokes. Antiplatelets are used for when a patient has a TIA. This is like usually the first choice treatment. So we talked about some of them already, but dipyridamole, ticodipine, and Plavix. So we usually give between 81 to 325 milligrams per day for aspirin. And we need to make sure all of the healthcare providers and dentists know that they are taking this. So we should make sure they know to tell them. And this starts, you stop taking it 10 to 14 days before an operation because it could cause excessive bleeding. Since, again, antiplatelets kind of, if you don't want an antiplatelet effect, then you don't want it in surgery. And oral anticoagulation, so that's warfarin, and then we have some direct XA inhibitors. So these are used when a patient has atrial fibrillation, and this is to prevent stroke because when you have atrial fibrillation, you have a higher risk of throwing clots because they keep since atrial fibrillation is like your heart, your atria is contracting so fast that there's not really any time to do anything to like filter anything out. So you're going to have clots still, and that could cause a stroke. So we want to give you oral anticoagulants, right, to lengthen the time before a blood clot is formed, even though you do have atrial fibrillation. And then direct XA inhibitors are more common because they're not, continuous monitoring isn't required. And so I got a lot of questions on like what's the difference between an anticoagulant and an antiplatelet, and like I was confused too. So an anticoagulant, okay, make it so the time is lengthened before a blood clot forms, right? While antiplatelets are making sure the platelets don't clump together. Okay, so essentially they're doing very similar things, but they're just different kinds of medications, okay? And then tissue plasminogen activator is called TPA. It's for ischemic stroke only. You do not want to give it to a patient in hemorrhagic stroke. You will kill them. Because what is a hemorrhagic stroke? It's bleeding in the brain, right? So if we give them medicine to decrease clots and start bleeding, right, to start making blood flow, then that's not going to be a good thing for hemorrhagic stroke, right? So we need to make sure it's an ischemic stroke, all right? Usually we take an MRI, whatever, before we do give this. And we need IV to reestablish the blood flow through a blocked artery, and we want to keep the control of the blood pressure to under 185 systolic, at least for the first 24 hours. So here are some reasons where you can't have the TPA. These are like the common reasons. There's a lot more, but I'm just going to focus on the common reasons. So if it's greater than 4.5 hours since you started having symptoms of the stroke, we don't give it to you. If you're receiving anticoagulants or you have been in the recent past, then we don't give it to you. Uncontrolled hypertension, and if you have rapidly improving neurological signs, then why are we going to give it to you, right? And then for hemorrhagic stroke, I just kind of put this as the anticoagulants and antiplatelets are prohibited because, again, that's what I said, that it would, your blood vessel's already like bursting and it's bleeding, and so we just want to control BP right now, usually done through IV meds. And so that's about it for strokes. And then lastly, we're just going to do a few seizure meds. So the meds that we can use for generalized tonic, clonic, and focal seizures are phenytoin, carbamazepine, phenobarbital, divalproex, and primidone. And phenytoin causes gingival hyperplasia and hirsutism, so we need to make sure that patients know that, and they need meticulous teeth care because gingival hyperplasia is the gum line is thickened, and as for carbamazepine, do not take it with grapefruit juice. I think grape juice is fine, but grapefruit juice, no. And instruct the patient to report visual changes, and don't stop it abruptly, because that can cause seizures, of course. And phenytoin relies highly on the liver. So if someone has elevated liver enzymes, if their liver is not so good, don't give them phenytoin. Okay? All right. So for absence or myoclonic seizures, we have ethosuximide, divalproex, and clonazepam, which is also called Klonopin. And again, these are used for absence or myoclonic seizures. The common side effects of just all seizure meds in general are like diplopia, drowsiness, ataxia, mental slowness. So basically anything with the CNS, because what it's doing is it's trying to increase the threshold of your seizure. So you can imagine there will be side effects with the CNS. But the best thing we can do for seizures is to give them the right dose to control their seizures without having too many side effects. And then some other seizure medications are gabapentin, topiramate, lamotrigine, tiagabine, Keppra, and Lyrica. And again, they're the same side effects, but Lyrica can be used in focal seizures if other treatments aren't working. So as like an addition, you might have heard for commercials on it, but yeah. All right. Well, I hope that helped you. Here are the meds, and good luck. Bye.